Welcome everyone to the Specialty Recruitment Assessment 2020 webinar. Okay, so let me just introduce myself for those of you that haven't met me. My name is Muhibur Rahman. I'm a portfolio GP based here in Solihull. So what that means, I'm a GP with multiple roles. So my own practice is in Birmingham City Centre. It's a small practice. There's just 2 GPs there, myself and sort of someone I studied with from medical school. And then I'm a consultant in medical education. So I teach for eMedica as the medical director there, but also I examine for the GMC, for the PLAB Part 2. I write for the prescribing safety assessment. I'm an OSCE examiner for Liverpool Medical School. I've been teaching about situational judgment test and the specialty recruitment assessment and the predecessor of this exam for about 12 years now. I teach all the way up to MRC GP, GP trainers and examiners. And I've trained about 35,000 delegates over the last 15 years, doing various courses from medical students all the way to post-finishing GP training careers. And then I have multiple clinical roles. I work in detox, I work in a secure unit for women with severe mental health and so on. So that's what a portfolio career is. It's someone that does multiple roles, okay? So as I said, a big part of what I've been teaching over the last decade plus is actually around helping people get into specialty training and then succeed in their membership exams. And so that's really how I'm coming about to teaching this webinar today to those of you joining us. So let's look at what we're going to cover and how the webinar will work. So what we'll do is I'm going to start with an overview of this exam, the Specialty Recruitment Assessment. We're then going to go through some exam style questions. So we'll look at the clinical paper first, and then we're going to look at the SJT paper. Then we're going to look at some revision planning, how to succeed. What are the common mistakes that lead people to fail? And then how can you avoid those? And then the other side, what are the things that are common, because we've been teaching this for so long, we've collected data over many years, about those that don't just pass, but really do well and end up with direct offers, those in the top 10%, and those that, score really, really high scores. How do they prepare? What kinds of things do they do? Okay, let's just go through what we're going to cover. So as I said, I'm just going to start with an introduction to the exam. Then we're going to look at how the different specialties use your score, because it's the same exam for all 9 specialties that use it, but each one uses it in a different way. And then we're going to look at some practice questions just to show you the kinds of questions that you might get. So we'll look at some clinical questions, and we'll look at both types of professional dilemma SJT question. And then we're going to look at revision planning. So why do people fail, how to avoid it, how to do really well, okay? And then as I said, I'll take the questions at the end. And the reason for that is we've been teaching this for a long time. You might find that the question that you want to ask, I'm already going to answer in the teaching that's going to happen. So it saves time not to repeat the same answer many times and not to answer questions about things that I've already covered. Do you see what I mean? If you want clarifications on anything, ask them at the end if it's not clear, okay? And then we're due to finish 8:30, okay? I'm going to try to stay strict to time. I appreciate your evenings are precious, and like many of us, we've got a school run in the morning or a clinic and so on. Right, so let's start with the basics, overview of this exam. So first of all, the Specialty Recruitment Assessment, also called the Multi-Specialty Recruitment Assessment, MSRA or SRA, it's the same thing. It's a single assessment that's used as part of the recruitment process for ST1 or CT1 entry for training by 9 different specialty training programs, okay? So the exam, doesn't matter which specialty you apply to, and if you apply to more than one, you'll only sit the exam once, and the score will automatically be populated via Oriel to all the specialties, okay? But they all use it in a different way. You cannot sit this exam unless you successfully apply for training and have your application accepted, or you've been longlisted, and then you get invited to book the exam. You can't just book it, or you can't just sit it outside of recruitment. It's not a standalone exam, it's part of the recruitment process. As a result, because it's a recruitment exam, there's no cost to it. There's also no maximum number of attempts. If someone didn't get in one year, they wanted to apply a following year, they could do that. That's not going to happen to you guys, because we're going to look at the things that are going to help you get in first time, or at least maximize your score so that you get the best score possible. Now, the exam's available all over the world. There's venues in many different countries, and the dates for it for round 1 are the 3rd to the 11th of January. So once you submit your application, the applications are open now. You'll get an email telling you that they've accepted your application, you've been longlisted. Log into Oriel, and you'll see that. And then you'll also have to log into something called Pearson View. They're the people that administer the test. And you'll be able to select your own location and date. So from the 3rd to the 11th, you can pick which date. The only date you can't pick is that there are some Sundays in that within that window. The exam centers are not open on Sundays, but otherwise you can pick where you sit it. Outside of this window, there are no dates for this round, okay?
The whole thing lasts 2 hours and 55 minutes, and there's 2 parts.
It's not a pencil and paper exam, it's a computer-based exam. So the first paper will be the professional dilemma paper, which is a situational judgment test.
That's going to be 95 minutes in 2020. Then there's a 5-minute gap.
And then you have the clinical problem solving paper, so clinical knowledge, and that's 75 minutes. Now, the timing for the 2 papers is completely separated. i.e., if you were to finish the professional dilemma paper, this one, 5 minutes early, you can't get 5 minutes extra for the clinical paper. They're 2 separate papers, you just happen to do them one after the other. And then there are multiple equated test forms. So because the exam's running on multiple dates over this sort of 2-week block, on every day, but not just on every day, okay, every sitting, the exam's different. When you sit down and you press start, you'll be randomly allocated one of many versions of the exam. The person sitting next to you will be doing a different exam. They'll have different questions to you. The person sitting on this side will have different questions to you. The person on the next day will have different questions to you, okay? But they're equated, so questions are graded. So, you all have the same proportion of easy, medium, hard questions so that we can compare. But you're not going to have the same questions because otherwise, can you see people that sat it later, they might find out some of the questions from people that sat it earlier and essentially try to cheat the system, okay? Even on a given day, you're all going to have different questions, okay? But we can compare you because you'll have the same proportion of easy, medium, hard, i.e. they're equated test forms, okay? Right, okay, so we're going to look at now how different specialties use your score, okay? So we're going to look at how different specialties use it. Just before we do, and before we do some actual questions, I want to show you how the poll function works. So look, I'm going to launch the polling. Tell me which specialty or specialties you are applying to. You can click more than one if you're applying for more than one specialty. So you'll see now a poll should come up on your screen. Those of you that downloaded the Zoom software, and just click your response. Just going to give you a few seconds to do that. Okay, that's time, fine, thank you. So that's how the poll system works. Now, fantastic, really love to see this. Every single option has been picked. So, at least, not even one, actually, at least 5 people are applying for any different specialty. And there's actually, for GP, there's hundreds of you. Okay, so fantastic. So GP is the most popular, followed by sort of psychiatry, radiology, obstetrics, lots of people for that, neurosurgery, sexual reproductive health, ophthalmology, big group, and then quite a few of you for broad-based training. So that's good. Broad-based training hasn't happened for a few years. It's come back this year, okay? Right, so let's look at how these different specialties use the score. So let's say now, some of you might have picked more than one option because you've applied, let's say you've applied to GP and psychiatry. You'll sit the exam only once. The same score will be put into your oral application for GP and for psych. Let's say you've also applied for radiology. The same score will go there. But you see, a score that will get you to the next part in psych might not get you to the next part in GP. And a score that might get you there for GP might not get you there for radiology. Why? Because competition ratios are different for different specialties, but they also use it in different ways. Okay, so let's look at that. So as GP was the most popular, I'm going to start there, and actually I'll just sort of go in alphabetical order that we picked there. So GP is the one that gives this the most weighting, okay? So in GP, 60% of your total rank is made up based on how you do in the specialty recruitment assessment. But in GP, the 2 papers are not even. So the clinical is worth 20% of your total rank, and the SJT is worth 40%, i.e. twice as much as the clinical for GP, okay? The other 40% is made up by the stage 3 selection center, or the GP stage 3 exam, which is 4 stations. There are sort of consultations with patients, relatives, colleagues, and then a written essay paper, okay? So that's 40%, and 60% is the SRA, all right? Now in GP, if you can be one of the top 10% in the country, which equates to a standardized score of about
550 or more,
don't worry about what that means. Essentially, you're in the top
25%.
I'll explain the scoring a bit later. But in GP, it's possible to get a direct offer. You can skip the selection center stage. If you do really well, get a direct offer. What that means, that will increase your chance of getting your first choice, okay? And that's particularly important this year, because this year competition is going to be for popular areas and popular specialties going to be much greater than any previous year, because this year, all doctor jobs, apart from public health, are on the shortage occupation list. What does that mean? That means that a graduate from anywhere, international graduates and UK graduates, will all be ranked alongside each other just based on score. Whereas in previous years, doctors that needed sponsorship for tier 2, they would be ranked separately. They'd only be ranked after doctors that didn't need sponsorship had been made offers. What that meant is someone was applying for GP in somewhere like London. They had almost no chance of getting in if they needed sponsorship. Why? Because all the London jobs would be filled by people that didn't need sponsorship. But this year, they're all on an equal footing. So it's going to be more competitive as a result. Okay. Neurosurgery is a specialty that gives it the second most weight. 40% of your total weight in neurosurgery is from the SRA. The other 60% is from the interview. Radiology, two things about radiology. First of all, it's a third of the total weight. The other 2/3 come from interview. But radiology is ultra competitive. They fill all their jobs in round one, and they have done for many years. And so what they do is they actually use the SRA as the means to decide who gets an interview in the first place. To give you an idea, last year, about 1,000 people applied, okay? And they just interviewed the top 600. Of those, 300 got jobs after the interview, okay? So, you've got to be in the top 600 for you to get an interview in neurosurgery. And then once you're, radiology, and once you're there, it's then 1/3 of your weighting. The other 2/3 is from interview. Psychiatry and child and adolescent mental health, it's 1/3. The other 2/3 comes from interview. However, again, with these two specialties, if you can score 541, so that's a lower cutoff than GP, you can get a direct offer. Okay. You skip the interview completely and just get an offer. Again, increase your chance of getting your first choice. Obstetrics, it's 25%, and then the other 3/4 is going to come from the interview. And then sexual and reproductive health is the same, 25%. Ophthalmology gives it the least weighting, 13%. The other 87% is at the interview, okay? Now, when I say interview, interview for each specialty is different. Some, it will be a clinical station and a communication skills station. Some, it will be a formal structured interview. Some, there'll be a portfolio station. You need to do some research for each specialty. Today, we're just going to focus on the SRA. We haven't got time to also cover, individual specialty, this many specialties, the next steps, okay? For those that are doing GP or psychiatry, we do have separate courses to help with the stage 3 assessment and to help with the psychiatry interview. Then broad-based training, they use it the same as you'll do the GP exam. So you'll do, the GP stage 3, you'll do the SRA, but they give the same proportion and weighting as the GP entrance, okay? So broad-based training is this program where you do 4 different specialties, 6 months each. So IMT, i.e. medicine, peds, psych, and GP. You do sort of 6 months each, and then you pick which one you want and you enter into ST2, CT2 level of that specialty at the end of broad-based training without having to apply again. Okay, so that's come back. It's only available in Northern Ireland and Scotland this year. Previously, it was available in England. Right, so in terms of scoring, you get a separate score for the clinical paper and for the SJT, and your initial score will be turned into a standardized score and allocated to a band from 1 to 4. 1 is the lowest, 4 is the best, okay? The standardized scores out of about 330 for each paper. Now, this is long-term data we've collected over more than a decade, okay? Your cutoff will be slightly different to this because they'll base it on how does your cohort do? The people that study in January, how do they do, okay? But to give you a rough idea, band 1 is a very poor level of performance, okay? Band 2 is below average, band 3 is good, band 4 is excellent, okay? Look, only the top sort of 14% are in band 4, all right? About just over half will be in band 3, and then like band 2 is about 20-something%, the bottom 7% are going to be in band 1. Now, as I said, different specialties use this in different ways. So for example, in GP, if you score band 1 in either paper, even if you have 100% in the other paper, you basically have failed this exam and you will not progress to the next stage, okay? But remember, it's not just a pass-fail exam, it's competitively ranked. Every mark matters, you see. Remember, this score carries over and gets added to your interview or selection score to make up your total rank. So imagine you had 2 people, they both got band 3. One got 290, one got 270, and they both got the same interview score. Can see, although they both got band 3, the one that got 290, their total score is going to be higher. They're going to get the job, and the other person might not get it if there's only 1 job left. So even 1 mark can make a difference. So don't look at this as a pass-fail. Look at it as I want to get the best score possible. Now, as I said, different specialties use it in different ways. So in GP, you need at least 2 band 2s to get to the next stage. Okay. In psych, they don't use this actually for shortlisting. So in psych, whatever you score, you will get through to interview as long as you've met the eligibility criteria, okay? But of course, because it's making up a proportion, right? It's making up, in psychiatry, 1/3. If you score really poorly, if you score 2 band 1s, then unless you do brilliantly in your portfolio and your interview, it's going to drag down your total, isn't it? And you might not get a job. You might not get an offer. You might not get a job where you want, but they don't have a minimum cutoff. Whereas, look, 2 band 2s for GP would get you to the next stage, although you might not have a chance at somewhere very competitive like London. whereas 2 band 2s wouldn't get you shortlisted for radiology, probably also for obstetrics. Why? Because they're going to only interview so many, and they're very, very competitive. Okay, so the better you can score, the more your chance of getting to the next stage and then getting a job. So what will happen in terms of results? The results will come out around the 24th of January, and there's 3 possible options. Okay, and then another one for GP and psych. So for GP, you could get an email to say, look, you got band 1 in either paper, you failed, so we couldn't rank you at all. You apply again in the following round or next year, resit the exam. Or you could get an email saying, you've been ranked but not shortlisted. So in some of the specialties, let's say radiology, you might get 2 band 2s, but they might say you ranked 700 and we only interview in the top 600. Again, your application's over. You could apply next year, because radiology does not have a round 1 re-advert or a round 2. They fill 100% of their jobs in round 1. So you have to wait till next year, okay? Or the email that you want, congratulations, you've been shortlisted, log back into Oriel and book a slot for interview or selection center. So you log in and you book your interview, okay? And then for GP and psych, if you score really well, so you can get a direct offer. What that means is you skip the interview, you just get a job straight away, okay? So it means you've got a very good chance of getting your first choice. Okay, so that's how that's going to work, okay? How different specialties use your score. So you see, the same score that might get you through for psych, or will get you through for psych, because I have no minimum, might not get you through for GP if you get band 1. The same score, if you've got 2 band 2s, might get you there for GP, might not get you there for obstetrics or for radiology, because they've got limited number of interview slots, right? More competitive, for example, all right? So what you want to do is, don't aim to just scrape through, aim to get band 4s, the best score possible, okay? That's what you want to aim to do. So let's move on and talk about the clinical problem solving paper and do some questions, all right? So the clinical paper is 75 minutes. And in that time, you're going to answer 97 questions. You've got about 45 seconds per question, okay? It's tight. Now, only 86 questions carry marks. So every paper has 11 questions that are for piloting purposes. They're worth no marks whatsoever. They won't be labeled in any way. They won't look any different. You won't know which ones don't count. You have to take all 97 seriously. You get 1 mark for each correct answer. And if we look at the long-term data, average scores about mid-70s in terms of percentage. Band 2 mark long-term data about 52%. So you get less than that for GP, your application will be over. Band 4 mark, this is what you want to aim for. Band 4, you want to be above this, 85%. Okay, that's a really good score. And the highest mark, more than 1 doctor scored 100% in this paper. Okay, that tells you something about the level. So the level of knowledge being tested is the knowledge expected of a doctor who's just started F2. You expect you to be able to manage things, to make diagnoses, to know what's the right test to do in which situation. It's harder than finals, but it's not at the level of membership. That doesn't mean it's not a challenging exam. It's a really challenging exam. It's challenging though because of its breadth. This is the curriculum. As you can see, basically everything in medicine, it can come in this exam, okay? And roughly the questions are evenly spread between this. So for example, cardiovascular, the number of cardiovascular questions is going to be similar to the number of infectious, hematology, immunology, allergies, genetics together, you see. So broadly speaking, they're spread between these topics. As you can see, it's everything, okay? Now, some of the questions will be set in a GP setting, some of them will be set in a hospital setting, but they could cover any of these specialties, okay? In terms of the format, there's no negative marking. So look, don't ever leave a question behind. If you're not sure, just guess. You don't lose anything, okay? But if you leave it behind thinking, I'll come back, what you might find is run out of time, all right? Because you've got 97 questions to get through and only 75 minutes. It's tight. Now, there's 2 main question formats: extended matching questions, and they're all blocked together, and single best answer questions, and they're all blocked together. So extended matching questions, they come in sets of 2, 3, 4, or 5. And I'll show you an example of that in a minute. And then single best answer questions, there's like 5 options usually, and you pick one, which is the correct answer, okay? Now, within those, some questions might have an algorithm, a picture, okay? There might be an algorithm, you've got to complete part of a guideline. You might have to drag the right label to the right section. I'm going to show you an example of that just so you see. Some questions might have a picture. So they might show you, an ECG or a blood report or an MSU or something like that, and ask you to interpret those results or manage it. And you might get 1 or 2, or you might get none, multiple best answers. So this is a question where there's more than one right answer. So, for example, this patient comes to see you, they're worried about their risk of colon cancer because their mother's just been diagnosed. Which 3 of the following are risk factors for colorectal cancer? And you get 1 mark for each one that you get correct. Okay, so there might be more than one right answer, so watch out. You may not get any of those. The most of the questions are EMQs and SPA. So we're going to start doing some questions now, okay, just to get you into the flow of what does it look like. I will put the question up for about 35 seconds. After that, the poll will come up. When the poll appears, you've got 10 seconds to make your decision, okay? Those that don't have the poll, just write it on a piece of paper. Please do not put it in the chat or the Q&A, okay? Here we go. I'll turn my video off. And that's time. Thank you very much. Okay, so very interesting. Every single answer was picked. Just highlights that it's a hard question. Okay. One of the things is, you know, like we've only got a short amount of time today, so I'm deliberately want to expose you to some of the more tough questions so that I can teach you a bit of technique, as well as covering some important things. Okay. So the most popular answer was C, but we had every single answer picked. Okay, the least popular answer was D, cyclizine. So now something important about this is what we call a negatively framed question. So you've got this patient terminally ill, they've got metastatic cancer, they've got severe nausea and vomiting. These are key words, right? You know, the symptoms, the diagnosis, and you know, someone suggested that maybe they might benefit from a syringe driver. So which one would not be helpful? Do you see what I mean, that this is negatively framed? We're not asking which one would you give this patient. We're saying which one would not be helpful to deal with their symptoms. What are the symptoms? Remember, the symptoms are severe nausea and vomiting, okay? So the one that would not be helpful is B, hyoscine hydrobromide, okay? And that was not the most popular answer. The most popular answer was dexamethasone. So all of the others, levopromazine, dexamethasone, cyclizine, haloperidol, they can all be used as antiemetics, okay, in different scenarios. Dexamethasone is particularly useful if someone, for example, got brain mets and they've got raised intracranial pressure, which can cause vomiting. It can be very useful for that, okay? But all of the others are, hyoscine hydrobromide is used for, in palliative care, it's used to dry up respiratory secretions. You know, sometimes people have excess respiratory secretions. It's very useful to dry those up, okay? So that wouldn't be useful for these symptoms. It's not that it wouldn't be useful at all in someone terminally ill. You can see the question's asking about alleviating his symptoms, which are severe nausea and vomiting. So that's why B is the one that you wouldn't give. Okay, let's move on to the next one. Okay, I'm not going to launch any polling for this one, okay? I just want you to think about what's going to go here, what's going to go here, and what's going to go here. Maybe write that sequence down on a piece of paper. In the exam, you'd actually be taking the labels and dragging them to the right place. I'll show you that in a minute. Okay, and that's time. Okay, so everyone write something down if you haven't done so already on your piece of paper as to what you're going to do first. Okay, so what we've got here is you've got someone who's a child, they've collapsed in the car park, all right? And so this is basic life support, all right? But the key thing is that they're a child. So pediatric basic life support. Now, most children, if they go into arrest, will they have a respiratory arrest or a cardiac arrest? Type that in the chat. What do you think? Yeah, absolutely. Most children, if they go into arrest, it's respiratory. And that's why the most important thing to do first for a child is breaths. So we do 5 rescue breaths first. You'd be taking that and you drag it there. And then after that, you give 15 chest compressions. And then after that, the ratio is 15:2 in children, okay? And so that's the right sequence, all right? And you get 1 mark for each of those in the exam. So pediatric BLS, you know, it's usually respiratory, so it's 5 rescue breaths, then it's 15 chest compressions, then it's 2 to 15, right? Whereas adults, most adults have cardiac arrest. That's why for adults, the first thing is compressions. So 30 chest compressions, and then the ratio is 2 to 30 for adults, okay? Right, let's do the next one. Infectious disease, here we go. And that's time. Thank you very much, everyone. Okay, great. So again, every single answer was picked by at least several people, actually, not just one. So it just highlights the difficulty. But I'm very happy to see, actually, more than half of you got it right. Okay, just over half, actually. So we've got someone with Lyme disease, had their first dose of doxycycline, and they come back within sort of half a day, 12 hours. They've got a bit of fever, flushing, tachycardia, blood pressure's sort of borderline. Okay, so what's likely to be going on here? This is a specific type of reaction that's known to happen when someone's treated for Lyme disease. It's called the Jarisch-Herxheimer reaction. Okay, you can also get it when someone's being treated for various other illnesses with antibiotics. Actually, almost any antibiotic can cause it, but it's actually particularly common when people are being treated for syphilis. Just 1 second. Anna, I think your microphone's on. Thank you. But also specifically to doxycycline, okay, when people have, and what happens is it's a sign that the antibiotic's working, and it's release of toxins coming from the treatment. And so people often think, oh, you know what, I'm getting a side effect, and they want to stop. But what you need to advise them, just carry on. After about 24 hours, it settles down. Okay, so let's move on to another question. Emergency care. And that's time. Okay, thank you very much. Okay, great. So key thing here is that this child is 9. Okay, so look, they've had something to eat, and now it looks like they're having an anaphylactic reaction, right? Okay, so in anaphylaxis in a child, we want IM. All right, why? Because what's going to kill you is your airway closing up. So the additional time to put in an IV line is going to add delay. Okay, of course, you're going to want to get an IV later because you want to give them steroids afterwards, you want to give them antihistamines afterwards. All of that's given IV. So you will get IV access later. But the initial phase, IM, and it's 1 in 1,000. The dose when we give IV is different anyway. Okay, it's 1 in 10,000. So IM, 1 in 1,000. And then, so, you know, basically we can eliminate D&E. It's either A, B, or C. And then it's just based, the amount is based on age. So he's 9. So the correct answer is B, 0.3 mils. Okay. If it was under 6, it'd be 0.15 mils, 150 micrograms. Because he was between 6 and 12, it's 300 micrograms, so that's 0.3 mils. And then 12 plus and adults, it's 500 micrograms, 0.5 mils, okay? So those are all examples of single best answers. Do you see? The questions will have a title. You'll know what question you're on. There's a question, and then there's 5 options. Now I'm going to show you EMQs. Now, EMQs in the exam, they come in sets of 2, 3, or 4. And within each set, sometimes even 5 actually, there's only 1 question per screen, okay? Now that's different to how all the books and most online services lay out their EMQs. They tend to put the whole set on 1 screen or 1 page, which makes it easier than the real exam. Now our online revision, which I'll show you what it looks like later and how to use it to revise effectively, we deliberately wanted to make it as close to the real exam as possible. And we frequently get feedback that people did find it the closest thing to the real exam. And one of the reasons is our EMQs are 1 question per screen, for example. We designed it from the ground up to map the real exam. So what we're going to do is we're going to do 3 questions in a row without me launching any polling. So just write down your answer on a piece of paper. Please do not put it in the chat or in the Q&A. After 45 seconds, the screen will automatically move forward. So you get a feel of how long you've got in the exam. If you have 45 seconds, you'll finish the exam and have just 2 minutes left to go over any you're unsure of. If you want to build up 5 minutes to go over any, really you've got about 43, 44 seconds, okay? So here we go. There'll be no audio and you won't see me while these 3 questions go on, okay? They'll happen one after the other. Here we go. we're back to the first question now. I'm just going to launch the poll, okay? Don't think about this now. You've already seen the question. You're just entering whatever you've already selected, okay? So this was the first one of the set, okay? So just a few seconds just to put down whatever you actually already decided. Okay, that's time. Thank you very much. So very interesting. Every option was picked except for H, but all of the others were picked. The most popular was G, vitreous hemorrhage. That's not the right answer though. So you got someone now in the picture question, really important. Look at the picture and look at the scenario. They're both important. So if we look at the picture, first of all, we've got what's classically described as a stormy sunset. Look, sun setting here, storm clouds here, okay? Then look at the history. Poorly controlled high blood pressure, worsening vision over 2 days. That's very important, okay? This isn't sudden onset, it's gradual, 2 days. And then they've got floating dark spots. And then you've got the stormy sunset. This is central retinal vein occlusion, okay? D, okay? Second one, again, relaunch the polling. Here we go. And 2 more seconds. And that's time. Thank you very much. This time, every single option was picked, including H, okay? The correct answer here, though, if we look at the picture, this is what we're looking at. This is called a cherry red spot, a prominent fovea. Again, same risk factor, poorly controlled hypertension. Here, sudden onset reduction of vision, painless, that's very important, and visual acuity is severely reduced to counting fingers only, okay? That with the cherry red spot, this is central retinal artery occlusion, okay? Artery occlusion, bang, think of a stroke, okay? Vein occlusion, you get vein, it tracks back to other veins, okay? That's why you get the storm cloud, if you like, okay? And that's why it's gradual, it takes longer to develop, all right? And then the third one, I'll launch the polling. Here we go. And that's time. Thank you very much. Okay, so again, every single option was picked, but the most popular answer by a big margin, 80% of you got this one right. So this is a question that will be graded easy, is B, foreign body. This is a healthy fundus, looks normal, okay? So now we look at the history. You know, gritty feeling, is working on a building site and it's watery, but visual acuity is normal with normal fundoscopy. That fits with, you know, probably got a bit of grit or something, a foreign body in the eye, right? Okay, so, you know, that's B, the right answer. Okay, well done. Okay, so just show you a closer image. You can see stormy sunset, central retinal vein occlusion. Sun setting here, vein occlusion, you get tracking back to other veins. Close up of the cherry red spot, prominent fovea, okay? Sometimes you also get some pallor here, but this is the main finding. Here's another example. Look, bang, fovea, cherry red spot, okay? And this is healthy, all right? Normal. Okay, so in terms of clinical, how are you going to prepare for the clinical? So you want to do active learning more than passive learning. Passive learning, example of that is reading a textbook, okay? Active learning is if you're going to read, summarizing or making your own notes, or doing questions, you know, just like we've been doing now, when you actually have to think about it. Because, you know, if someone reads a textbook cover to cover, if someone says to them, prostate cancer, go, they can regurgitate, okay, incidence is this, you know, these are some of the symptoms, these are, but that's not in the exam. They're not asking you to recall facts. You'll see the exam is like we've done, they will give you a case. It's about applying that knowledge, okay, to a scenario. And so that's why you want to do questions that will allow you to be prepared for the kind of thing you're going to get on the day of the exam. You want to cover the curriculum. It's a lot to cover. It's not that they want you to know everything there is to know about ophthalmology or about musculoskeletal medicine or about cardiovascular. It's they want you to know a little bit about everything. It's a very broad curriculum. That's why you need to allow enough time. And you want to practice realistic questions. Then you want to work on exam technique. Some of you that got that first question wrong about hyoscine hydrobromide, it's not a lack of knowledge. Okay, it's that maybe you missed it was negatively framed, was asking which one isn't helpful, okay, for that particular patient, or you missed the fact that, you know, not helpful for his particular symptoms, because it is helpful in palliative care for lots of patients who have secretions, but that particular patient's symptoms were, you know, severe vomiting and nausea, right? And so it's not helpful for that particular situation. Incidentally, it can be used for travel sickness, but not for this type of sickness. Okay, so, you know, you want to work on exam technique. Now that's, you know, spotting keywords, like least suitable, most suitable. That's reading the symptoms. And then doing some timed mock exams so you get used to, because it's tight for time. That's why we wanted to do some questions to time, okay? Other things in terms of preparing is to remember what the questions will be mapped to. So we showed you the curriculum areas, but every question will be testing your ability to answer a question that relates to one or more of these things. So some questions will be related to the right investigations. Some will be about making a diagnosis. Some will be about emergency care. Some will be about, so think about the emergencies a junior doctor should be able to deal with. Anaphylaxis, we covered that. Okay, life support, sort of sudden collapse, acute severe asthma, acute coronary syndrome, those kinds of things, okay? Prescribing. So there'll be some questions specifically, like we did the one about prescribing in palliative care, right? About what you'd prescribe in different situations for different patients. And then management, not to do with prescribing. So for example, knowing who to admit to medics, who to admit to surgeons, who to send back to the GP. In a GP-based question, who to admit within 2 weeks, who, things like that. So how can you prepare in terms of learning some of the material? Well, this is the reading list, okay? I'm not suggesting that you try to read these books cover to cover, okay? Between them, there are several thousand pages, and the BNF is a reference text. It's not designed to be read cover to cover in any way. But they're useful to dip in and dip out of. So Oxford Handbook of Clinical Specialties and Oxford Handbook of Clinical Medicine, between them, they cover the whole curriculum for this exam at more than enough of a level for you to score really, really well. Not enough for membership, but you're not doing membership. So, you don't need a separate book for peds, and these two are enough, okay? Make sure you've got the 10th editions. And then BNF, spend half a day on the BNF. Read the first 10 pages, which has a section on pain management, on prescribing in palliative care, and on general principles of prescribing, which often come up. And then if you can, read the first page of each chapter, which summarizes the drug classes for each system, okay? Now, unfortunately, even the Oxford Handbook of Clinical Medicine Specialties 10th edition, both of those are already out of date in terms of clinical guidelines. So, for questions that relate to prescribing and management, non-prescribing, and sometimes what's the right test to do in certain situations, they're out of date for that. And that's because a lot of guidelines changed in 2018 and 19. And so, they've changed after these books were set to print. So in terms of reading guidelines, you could go through things like NICE CKS, but they're bulky, there's a lot to cover. The quickest way you can learn a lot of guidelines relevant to this exam is our clinical case cards. So we published the first edition of these August 2018. And what our team did is we spent several hundred hours between us going through the latest guidelines and then making really sort of concise cards. I'll show you, okay? So for example, in terms of, we've got febrile seizure here, okay? How do we manage it? How to diagnose it, how do we manage it? To see how it links to those questions. Iron deficiency anemia, the treatment doses, okay? What are the signs? So in terms of someone presenting for a diagnosis question, benign paroxysmal positional vertigo, BPPV, okay? Meniere's prophylaxis, and so on. Anyway, there's a huge list. It's 112 topic reviews, but they're in a really handy sort of deck of cards. Okay, it's just this big, fits into your purse, into your bag. And so it's the kind of thing, even if you've got no internet access, you're in A&E, in between patients, you can read one, 5-10 minutes, read the other one. What we've done is we've done the work of making it concise for you. So you can cover a lot of ground in a short amount of time. Even, you're sitting the exam in January, there's, we're coming up to about 60 days left, depending when you sit the exam. There's 56 double-sided cards. You just do one card a day, so 2 sides a day, 10, 15 minutes, without realizing you've covered 112 topics mapped to the things that are going to be asked in the question. So that's a really quick way to cover those, okay? And then the main thing you need to do is practice questions, right? Okay. Now, when we started running our courses back in 2005 was the first course, there wasn't a single book or online revision for this particular exam. And this exam was first used by GP. We developed the first ever service, and every year since then we've updated it. We've hired people to write questions that have done really well so that they know what the right level is, but we ask them to write original questions mapped to the exam, and then we try to make the screens as close to the real exam as possible. So there's over 2,000 questions. We've mapped the whole curriculum, all up to date with the current exam format. You have all the question formats, EMQs, SPAs, but we also have timed mocks, which is unique in that our mocks are all unique. They're not questions you've already seen regurgitated. So if you're familiar with the question, if we did those same questions now, you'd get them all right. Doesn't mean you've mastered them all, okay? when you do the mocks, they're questions you've never seen before. They're unique, okay? So we have full-timed mocks for both SJT and clinical. And then we also send you additional reviews throughout the period. So there's over 100 hours of learning. It's the minimum time. If you want to cover it once, including the reading, it's going to take you 100 hours. So if you haven't already started, I know a lot of you have already been using it for months. If you haven't started, you really need to make a start now. I'm just going to show you it and show you how you might use it, okay? And whether you use ours or not, I'm going to show you how to approach the clinical. We'll come back and look at SJT later. So look, we've got clinical, we've got SJT. So our clinical, they're mapped to those same topics that we saw earlier. So cardiovascular, respiratory, surgery, ENT, urology, hematology. You can see we've got same sections, okay? Now, how I recommend you use it, if you've got time to do all of them, then you could just go in sequence, but don't do cardiovascular 1, 2, 3 right at the beginning, because then in 2 months' time when you sit the exam, the last time you did cardio questions was 2 months ago, you've forgotten them all. Instead, do cardio 1, then the next day you might do respiratory 1, then you might do surgery 1, then ENT 1, and so on, until you finished all the ones. Then go back to the top, do cardio 2, respiratory 2, until you've finished all of those. Then go back and do 3s, okay? Once you've done all of these, and I'll just show you an example, okay? So, for example, if you do a cardiovascular question, when you click start, do you see it's laid out like the exam? So it's got a title, there's a question, there's a single best answer. When you click the answer, it will give you an explanation. Now, if you get it right, it's probably enough for you to read this explanation for concise review, okay? Now, if you get one wrong, now, do you see this is a question we'll be asking to pick 3, a multiple best answer, because some people have turned up to the exam, never seen one. So here, you want to pick 3, right? Now, if you get it wrong, see, I've got some of it right, but I didn't get it all right, okay? Now I'm gonna, as well as reading this, I might then, this is where you might pull out the cardiovascular section and read that up from the Oxford Handbook of Clinical Medicine or specialties. And then I'll just show you, can you see, this is a set of EMQs. And you see, just like the exam, 1 of 3, there's only 1 question on the screen, okay? You select that, you see your answer, 2 of 3, answer options are the same, different scenario. You see, that's how it is in the exam. 1 question per screen, for the EMQs. They're not all on the same page, which makes it easier, all right? And when you finish all of the blocks, which are mapped to the curriculum, that's when you want to move on to the mocks. So we've got lots of timed mini mocks and then 3 full timed clinical mocks, okay? So when you do a timed clinical mock, I'll show you, just like the exam, it's 75 minutes. Look, it's got a timer, it's counting down. You question number, that's how it is in the exam. You can flag questions for review, like in the exam. So let's say you didn't know, you guess, flag for review. Now, if you finish, you could just see the ones you flagged earlier and you go back and forward with buttons at the bottom. Now, if you use it from a phone or a tablet, it automatically adapts the screen to make it suitable for a phone or a tablet. And if you don't have time to do all of them, then what I recommend you do is start with whichever subject you're least confident in. Because what people do is they start with what they like. Like people that have done a lot of respiratory, they like to do respiratory because they get them all right, they feel good. But if you've done a lot of respiratory and you don't have time to do all of these, you're probably still going to do okay in respiratory. Like let's say you've done no ENT since medical school. Do all the ENT questions first. If you're going to run out of time, at least you've covered the things that you're weakest in, okay? And then there's SJT as well. I'll show you that later, okay? So there's over 100 hours of learning. For those of you that stay to the end of the webinar, I will tell you about an even better bundle in terms of discount. But if you use this code up until Tuesday morning, 11 o'clock, you can get a 15% discount, okay, if you've not already signed up, all right? That's on any subscription length. We have subscription lengths from anywhere from 1 month up to 1 year. We've had doctors that have been revising since last year, okay? So that's the clinical. I'm going to move on to the professional dilemma now, okay? So the professional dilemma is the first paper on the day of the exam.
You'll have 95 minutes to answer 50 questions. Only 42 are marked.
The other 8 are pilot. You won't know which ones are not counted. They'll all look the same. So you've got to answer all 58. Now I've put here timing in bold. A lot of doctors struggle for time. And if you can finish this paper and give every question your best go, even if you don't get them perfectly right, you can get the bulk of the marks because you get marks for being partially correct in the SJT. Whereas in the clinical, if you get it wrong, you get nothing, right? Look at the long-term data. Average scores much higher in the 80s. Band 2 score 70. Score in the high 60s in GP in this. Even if you get 100% in the clinical, you will not go to the next stage. But look at this, from failing to being in the top band, there's not much in it. So one question makes a bigger difference in the SJT than in the clinical, okay? So why are they using this? Because there's really good research that people that do well in the SJT will do well in the actual training. It's objective rather than essay type questions are subjective, which is what they used to use before, and it's machine markable. What it's going to do is going to give you a work-based or work-related scenario and test your decision-making and judgment. It does not test clinical knowledge, okay? Although some questions do test knowledge of GMC guidance and ethical guidance. So there'll be a difficult situation or professional dilemma, and every question will be testing against one or more of 3 competencies in the National Person Specification, which are these: empathy and sensitivity, professional integrity, and coping with pressure. Okay, so every question will test one or more of these 3. And then some questions, it will be useful to have knowledge of core GMC guidance. Okay, so let's do a question. Now, within this paper, there's 2 sections, all right? The approach to how you need to look at the questions and also how they mark is very different in section 1 and section 2. The questions are mixed up. All the section 1 questions are at the beginning of the paper. All the section 2 questions are at the end. They're roughly, but not exactly 50-50. Why? Because they might have a different number of pilot questions in one section or the other. So roughly equal numbers, maybe slightly more section 1 and slightly less section 2, okay? So section 1, you get a scenario and you have to rank options from best to worst, okay? Section 2, you'll get a scenario with more options. You have to pick things that go together to make one response. I'll show you what I mean. Let's do a section 1 question, okay? So in section 1, most questions will have 5 options. There may be the odd question with 4 options, okay? And so if there's 5 options, you rank them best to worst. 1 is the best or most effective option. 5 is the worst or least effective option. And what you do is in the day of the exam, you actually drag. So let's say now, you'll have 1, 2, 3, 4, 5 here. You have options here. You drag them into the right order, 1, 2, 3, 4, 5. You therefore can't put B and C joint second. It won't allow you to rank things equally. Everything has to be given a separate rank. Let me show you what I mean, because some of you might not have seen this type of question. It might be new to you. So it might be clearer after you've had a go. Here we go. Okay, you've got about 1:50. Okay, just remind people again, please don't put your answers in the chat or the Q&A. Other people may be thinking, okay? Write it down on a piece of paper, okay? Right, so that's time. I'll get you all to stop there, okay? So please write down your response, okay? What order you think you would do these in, okay? So remember, whatever you rank 1 is the most appropriate or best action. Whatever you've ranked 5th is the worst or least appropriate action, okay? Now, let's have a quick read through and then let me just put my video back. So let's have a quick read through and then we're going to see what people thought, and I'll show you what is the best order, how they mark and why, okay? Right, so you're just finishing, and when you're doing this in the exam, try to picture the scene. Now it's on computer. You haven't got pencil and paper to underline things, but in your mind, try to picture the scene. And then for each option, think about the possible outcome, try to visualize it. It will really help. So just finishing a busy night shift and you're exhausted, okay? There's night shifts where you'll be tired, but you're exhausted. Morning on-call doctor's called in sick. As you're leaving the ward, the senior nurse says, look, we haven't got someone. right now. So, medical staffing has said, would you stay on until the early afternoon when a locum will be available? So they found someone, but it's going to take them till the early afternoon. So it's the morning now. That's several hours, isn't it? Okay. They're asking you to do a whole morning and then some of the afternoon, but you're barely able to keep your eyes open and you can't concentrate. So it's not safe for a doctor that tired to be seeing patients, right? Okay. Now let's look at the options. Option A, contact medical staffing and refuse their request to stay on. So contact and refuse, very important. Just think about that. Let them know I can't do it. Option B, agree to stay on for a few hours, but say, look, I can't stay until the afternoon. I'll do some of the morning, but I can't stay till early afternoon when the locum comes. It's too long. Option C, agree to stay for a few hours and say, look, but I'll do a few hours. I can't stay till the afternoon, but I want a full day off later. So, I'll do 3 or 4 hours, but I want 8 hours back another time, like double time, basically. Option D, discuss a situation, so the whole thing, with your consultant, your clinical supervisor, and explain you feel it's unsafe for you to stay on. And option E, say, look, I'm too tired now. What I'll do, I'll come back in the early evening before my night shift tonight. Remember, you're on nights. Okay, so let's look at what's the best response. The best response is DAEBC. Okay, hands up, those of you that had DAEBC. You can use the raise hand option. Just want to see a rough idea how many people. Not many. Okay, great. So let's have a look. But quite a few of you. Okay, good. Well done. So let's have a look now. Did anybody, just 1 second, let me have a look. Yeah. Did anybody select ADEBC? Is anybody that selected ADEBC? Not that I can see. Okay. So some doctors think that they will do A first and then they'll do D. They think, what, they've asked me something and I can't do it, so they can start finding someone. And then to talk to my consultant is going to take longer. Is there anyone else that thought along that way? Yeah, okay, so there are a few people. And you see, this is a very common reason to lose marks in the exam. You see, they're not asking which order in time you would do them. They're asking better or worse. If you're only going to do one of these and that's your whole answer and you're not going to do anything else, which is the best response, the most complete answer to deal with that situation? Okay, and if that wasn't an option and you could only do one, which would be the best one? Not I do this first and then I do this. Think of the word or. Is this best, or is this best, or is this best, or is this best, or is this best? Not I do this and then I do this. If you think about it as an order in time, you're regularly going to lose marks in the SJT. They're not asking you to decide chronology. They're asking what's better or worse compared to the one above and the one below. Let's look at why, okay, and map back to those domains. Remember the domains: empathy and sensitivity, coping with pressure, professional integrity, okay? So the reason that D is the best option is, can you see that in DNA, both of these, remember you couldn't keep your eyes open, you couldn't concentrate. It's not safe for you to be on call when you're that tired. It's unsafe for patients, unsafe for your team. Excuse me. So in DNA, you can see in both of them, you're not staying on and putting your patients and yourself at risk. Of those two though, the reason D is better is that part of your role, part of coping with pressure, okay, is to recognize your limitations. Part of professional integrity is that if you see something that is unsafe, that you try to do something about it. And I can see in DNA, by not staying on, you're doing something about it. But in D, you can say no, but they're going to ask someone else. What you probably can't do is change the system, i.e. that medical staffing shouldn't ask a doctor that tired to stay on when they've just finished nights. There's a reason you're legally only allowed to work so many hours at night, right? What you're doing in D is by explaining the situation to your consultant and saying, look, I think it's unsafe in the situation. Look, they've asked me to stay on even though I've just finished nights and I'm so tired. And I think it's not safe. Because it's clear that one, you're thinking about patient safety, and two, you're challenging that inappropriate behavior. Your consultants in a position of greater authority can see, not only do they need to know that there might not be junior level cover until the afternoon, but they might then be able to go to medical staff and say, you shouldn't ask my juniors to work when they're this tired, it's dangerous. You see, they can actually challenge the system. So that's why if you're only going to do one thing, you should do D. It's the best option. It shows positive for more than one domain. If you could only do one and that wasn't an option, A is the second best option in that, look, they've asked you a question, you've let them know, look, I'm not going to do it. So they know they need to find someone else to hold that page, and maybe the registrar will do it, or sometimes even the consultant will have to, you can cancel clinic. That might cause inconvenience, but if you don't have anyone on call, that's unsafe, right? So sometimes the registrar might come out of clinic and hold the pager, and then the consultant might have to do the clinic, and it runs a bit late. People are a bit annoyed, but it's not unsafe. EBC, all three of these are lower down because of the fact that by staying on in some capacity, you're going to put patients at risk. Now, if you look at B and C, at the moment, you're so tired you can't keep your eyes open. Staying on now is the least safe option, okay? So that's why B and C are at the bottom. Of them, the reason that B is not as bad as C is that in B, you're just saying, look, I'll do a few hours, I can't stay for the whole afternoon. It's still risky. Whereas in C, you're trying to get personal gain out of an emergency situation, okay? And what they ask you to do is rank what a good doctor should do, not what you necessarily would do. Sometimes, you might ask for locum rates. Now, if it's a planned locum in advance, they need cover for next month, it's fine for you to ask for locum rates, but you shouldn't ask for locum rates in an emergency situation where they're only asking you, because of the fact that someone's called in sick. You see, you shouldn't try to take advantage of that situation. That's why C ranks worse than B. And if you look at E, can anyone think what the problem with E is? Why is E not higher up? Why is it not second or first? Because there's still some risk. Look, okay, if you're too tired now, you're not putting at risk now. If you go home now, have a sleep, come back in the early evening before your night shift, while it sounds nice, what's going to happen now at the end of your night shift? You've already started work early, okay? So at the end of your night shift, again, you're going to be overtired, potentially struggling to concentrate and putting patients at risk at the tail end of your night shift. Why? Because you've now again worked more than you should in one block at night. You see, that's a bit more subtle. Sometimes people miss that and put this higher up, but there's still some risk, okay? Whereas here, you're doing the safe thing, but in D, you're also challenging the inappropriate behavior, okay? So, excuse me 1 second. I just remove this. Right. Okay, so let's look at how they're marked. Now, section 1 questions are marked using what's called a keyed responses mark scheme. So every possible order has a number of marks keyed to it, okay? There's 20 marks per question where there's 5 options. So if you had D, A, E, B, C, you get 20 out of 20, okay? Now, what if you had 3 right and 2 wrong? How many would you get? The answer is it depends. Depends which 2 you had wrong and which 3 you had right. For example, if you had A and D the wrong way around, E, B, C in the right place, you'd get 18 out of 20 for that. You had B and C the wrong way around, but these 3 in the right place, you get 18 out of 20 for that. You had A the wrong way around, but all the others in the right place, you'd get 18 out of 20 for that too. Whereas if you had these 3 right, but you had C at the top and D at the bottom, you get a very poor score. Because although it's still 3 right and 2 wrong, it's not a straight percentage. It suggests poor judgment. So every possible combination has a number of marks keyed to it, i.e. DA EBC equals 20, AD EBC equals 18, DA BEC equals 18, CAEB, whatever. Even the worst order gets you 8 marks, okay? So if you get it right, you get 20. Even if it's wrong, you're going to get somewhere between 8 and 18 marks. But there's only ever one order that gets you the full marks. And that's really where the technique comes in, that if you can pick up some of those keywords and map back to those domains, some of those small things that'll help you go from a 16 or an 18 to a 20. It's only a few marks that makes a big difference by the end of the SJT. Okay, that's section 1. Let's do a section 2 question. Okay, section 2, you get a whole load of options. So, often there'll be like 8 options, and usually you're going to be asked to pick 3. Some questions you might be asked to pick 2. Key thing in section 2 is the word and. The 3 things that you pick need to go together to make one response. If you pick A, B, C, you're saying A and B and C together is one answer. Okay, so let's look at the section 2 question. Here we go. Okay, time's nearly up. If you've not made a decision, please make a decision now. And I'll stop you there. That's time. Please write something down on your piece of paper, not in the chat, not in the Q&A. Great. Okay, so let's have a quick read through. So you're treating this elderly gentleman. He's diabetic, but look, he's had a fall. It must have had a big enough impact on him that he's ended up in hospital. He's on the care of the elderly ward. Okay. And you notice that his sugars are spiking in the evening, each evening before dinner. You'd expect it to go up after someone's had their dinner, right? But before dinner, it's going up. Okay. And it's unexplained. That's an important key word here. We don't know why it's going up. Unexplained spike. Now, he's talked about his sweet tooth. Lots of diabetics have sweet tooth, all right? And you've seen his wife, who visits each afternoon, is bringing him sweets as a treat, okay? So you've seen that his wife is giving him some sweets, okay? So let's look at the options. Option A, the important word here is confront. So confront Mr. Jackson about his wife's behavior, all right? Option B, continue to monitor his bloods at least daily. Option C, monitor them less frequently than you've been doing. You've been doing it daily now. Option D, drop by to see Mr. Jackson while his wife's visiting and discuss his care and recent results. That was important with both of them. Option E, discuss his results with his wife and explain, look, sweet treats could impact his health. You know, you've seen him being given sweets by her, so she might not realize, okay? Option F, suggest to Mr. Jackson, you know, come in a couple of times a week, no more, all right? Option G, suggest some sugar-free treats that Mr. Jackson might like. And H, discuss the blood sugar levels with Mr. Jackson, that is important, and explore his diet. Okay, so the preferred response, the way to get full marks, is B, G, and H. Okay, B, G, and H. Once again, hands up if you had all three of those, exactly those three. Okay, great. Okay, great. So that's really good. I'd say that's probably about maybe, yeah, about 25% of you. Right, that's good. Okay, it's not bad. It's a hard question. Okay, maybe a quarter. All right, actually, it's gone up a little bit more. Okay, good. So now let's look at how these are marked and why. Okay, so first of all, in section 2, you don't grade or rank anything. You're not saying B is first, G is second. Hey, you're just saying B and G and H. So remember, section 1, think about the word or. Is this better, or is this better, or is this better? In section 2, you're thinking about and. You're saying B and G and H together is one answer, okay? So the way they're marked is if you get all three of these right, you get 12 marks, okay? So you had all three of those, you'd get 12 marks. If you had any 2 right, you get 8 marks. Any 1 right, you get 4 marks, okay? You didn't get any right, you get no marks, all right? So essentially 4 marks for each of these 3 that you got right. So you had all 3, you get 12. Now, do you see, even though the questions are about 50%, section 1 and section 2, each section 1 question is worth up to 20. Each section 2 question is only worth up to 12. So section 1 carries the bulk of the marks. Do you see that? Okay. Now, section 2, remember section 1, we're not looking at good and bad. It's better or worse. Sometimes they're all bad, sometimes they're all good. Section 2, there are some where there's something wrong. It either shows a negative for one of the 3 domains, or it goes against some kind of GMC guidance. So you could eliminate it. So let's look at which ones we might get rid of and why. And then I'm going to show you how you can know you've got full marks in section 2. Okay, really simple test you can do on the day of the exam. So option A, what's wrong with option A? Any suggestions? Well, remember, one of the domains is empathy and sensitivity. Okay, now imagine how, put yourself in the patient's shoes, right? How do you think you would feel if someone confronts you about somebody else's behavior? His wife's the one giving him sweets, okay? And if you wanted to approach him and discuss, that's one thing. But you confront someone about someone else's behavior, it's highly inappropriate. It's really, really likely to upset them. So it shows a negative for empathy and sensitivity, which is one of the domains that we're looking for. Do you see? Okay. What is empathy? It's thinking about other people's perspectives and how they would feel about things. Okay. Option C, look, at the moment, they're not controlled. If you measure them less frequently, they might get even worse, and it might take you longer to pick them up. So it potentially could lead to more harm. Okay. Option D and E I'm going to come back to, because lots of you picked either one of those, and that's why you're a bit upset. Okay. I can almost see the daggers coming through the screen. All right. Option F, look, again, think about how the patient might feel and how Mrs. Jackson might feel. You've got someone unwell, his wife visits him every day. He might benefit. Think about his emotional well-being, psychological well-being, not just his physical well-being. if you try to restrict, first of all, that's not your job. That's the ward manager that decides who visits when. But if you do that, think he might be really upset. He might be really lonely. It might affect his, recovery in terms of his mental well-being. Do you see? And so that's why F's out. Now we come to D and E. Can anyone put in the chat window, what's the problem with D and E? It's the same problem with both of them, actually. And this is where ethical guidance and GMC guidance, knowing when you can and can't do things according to the guidance, comes in. Absolutely well done. Lots of people have got it. Both D and E are a breach in confidentiality. Look, his wife's already there. If you drop by while she's already there and you start discussing results, that's confidential information. It doesn't say in any of the options, ask his permission or get his consent to share with his wife. He might be happy to see his wife, to have the treats. He might not want her to know all the details of his treatment. If he does want that, that's for him to say, or for him to give consent for us to give that. You can't just give it out. Being the next of kin or the spouse gives you no automatic right to confidential information in the UK. Okay, it's different in some countries. Similarly, E, you might have good intentions that maybe she stops bringing him sweets, but you can't discuss someone's results with their spouse without their permission, without their consent. So both D and E show a negative for professional integrity, one part of which is understanding when you can and can't breach patient confidentiality. Now let me show you how you know you've got it right. Read back your 3 together and ask yourself if it makes sense when you do them as one. So look, does this make sense? It's not in alphabetical order. Does this make sense? H is the first one I do, okay? Discuss the recent blood sugar levels with Mr. Jackson and explore that. Mr. Jackson, picture the scene. Last few days, every evening before dinner, your sugars have been a bit high. I just wanted to explore what you've been having, okay? So tell me what you had yesterday, for example. Breakfast, lunch, dinner, anything else, any snacks? Now he might say, oh, my wife bought me some sweets. He might also mention, you've seen his wife giving him sweets, but for example, he might also be having cake and custard when the lunch comes round, rather than having fruit. So you might realize there's some things that he could change as well. Do you see? And then G, say, look, as your sugars are still high at the moment, here's some sugar-free treats. I know that you've got a sweet tooth. You've mentioned it before. Here's some sugar-free treats that you might enjoy, but they're not going to affect your sugars because they're not actually got sugar in them. And then continue to monitor his blood sugar levels at least daily. Until it's controlled, at least do as much as you've been doing. You might even do it a bit more, but definitely not going to do it less frequently. Okay, so do you see, that makes sense together, doesn't it? That's one of the ways you've got it right. Whereas sometimes some options don't make sense together. For example, Kenzie, how could you continue to monitor it at least daily and then also monitor it less frequently? So B and C could never both be in the answer because they don't go together. We'll call that a pair. There can only be one in a pair. Okay, right, so that's section 2. Okay, now look, we've only got a limited amount of time today, so we've only gone through one question of each, but there's actually lots of things to think about in both sections, okay, that we can't cover in time here. But our SRA Crammer course, we've got a full day, of which 4.5 hours is for the SJT. We can cover in detail. I'll talk to you about it in a second. So how are you going to prepare for the SJT? First thing is you need to know, each of those domains, empathy and sensitivity, coping with pressure, professional integrity, they're broken down into subdomains, and each question will be testing specific subdomains. It's really useful to understand that so you can map them when you're doing questions, okay? We covered the detail of the subdomains at the course when we've got a whole amount of time for it. Read GMC ethical guidance and good medical practice, okay? I'll tell you on which sections are important. Understand the difference between section 1 and section 2. Your mindset's different, okay? In section 2, you can eliminate some options because there's something wrong with them. In section 1, you can't eliminate something because it's bad, because there might be others that are worse. They're not asking good and bad, it's better or worse. Okay, and it's comparative. How can you compare things until you know what the others are? For example, a lot of people, they will read A, see refuse, and in their mind they've said that's bad, and they've put that 4th or 5th. And they try and fit the others around that, and they end up getting a really poor score because they end up with all of them in the wrong place or 4 of them in the wrong place. Whereas it is, it's not about good and bad. Others could be worse, do you see? And the others were worse, okay? Sometimes all of them are bad. So you're comparing in section 1, whereas in section 2, so section 1's or, section 2's and, right? They've got to make sense together. So you could pick some things that are negative. They show a negative for GMC guidance or one of the domains, get rid of it. Shows a negative for empathy. This goes against GMC guidance and confidentiality. This shows a negative for empathy. I'm going to get rid of it. And then you might only be left with good options to pick from, okay? Practice questions, okay? And ideally you want to practice questions that are realistic and spend time understanding why. Sometimes people get a question right, but they don't understand why. When they do a different question, they're not necessarily going to get it right because they don't understand the reasoning why they got it right. It was a fluke. So in terms of ethical guidance, these are some of the things that you want to know. So that biomedical ethical principles of autonomy, beneficence, non-maleficence, justice, and how they interact and where they apply in case scenarios. Confidentiality, when you can and can't breach them, what the GMC says about disclosure. Capacity, advanced refusals, do not attempt resuscitation orders, Gillick competence, the Fraser guidelines, informed consent, why the Bolam standard doesn't apply but Montgomery applies, why Bolam's important for other things. Personal beliefs in medical practice, how a patient's beliefs might impact the care they'll accept and a doctor's beliefs might impact the care they could offer and how to handle that situation. Financial issues and probity, raising concerns about safety, safeguarding, child protection. All of these things, these scenarios can feature, and it's important to get a good handle on them. Now you can read these things from the GMC website, it's all freely available, but it's going to take you a long time. If you want to cover them all in a really concise way, we have a whole section on covering the core knowledge for the SJT in our SRA Crammer course, okay? So I'll just tell you about that. The SRA Crammer course, the morning we cover on clinical, the whole afternoon, the afternoon is longer, 4.5 hours is on the SJT, okay? One of the big things we work on is developing exam technique, which can make a huge difference. Two people did the same amount of work, one's got better exam technique, is going to score significantly better. We will cover high-yield clinical topics, and you'll do a 50-question teaching mock, okay? With detailed feedback and rapid reviews. And then I think what a lot of doctors find particularly helpful is the SJT mock. So as well as going through that core knowledge and introducing you to key techniques, we'll do a 24 question, 24 scenarios, and we go through in depth like we've done now. Half a section 1, half a section 2. We've been running this course for more than 12 years. We've been teaching SJT longer than anyone, okay? All the questions are unique to the Crammer course, so you won't see them on our online service or any books or any other online services. And they run in Manchester, Birmingham, London, and there's also a live stream option. Okay, so I'll show you where to find them. If you go to our website, which is emedica.co.uk, okay, and then here you've got a section on GP and specialty training, Specialty Recruitment Assessment Crammer. If you click there, these are the dates, okay? So we've got the bundle here, which includes the course and access to all 2,000 plus online revision questions and the mocks, okay? So you get that at a huge discount. You're only paying £20 extra rather than £89 for 4 months access. And then look, we've got Birmingham, there's a live stream. We've got London on the 30th of November. Birmingham's the earliest date, 23rd November. Then we've got Manchester on the 8th of December, back to 15th of December in Birmingham, and then 28th of December in London. That's like a week before that they start, okay? If you can't attend any of those dates, you can click subscribe now and get access to a video recording instead, okay? But if you can't attend either in person or live stream, the big advantage is any questions, any scenarios that you want clarification, you can clarify live. And then we've also got SJT questions on our online service, so both ranking and selection. And look, I'll just show you the ranking. Like in the real exam, you will actually drag them so that you get used to dragging. So you can see, look, you've got the options, you move them into the order you want. First, second, third, drag them into the order, and then you get an explanation, okay? And then there's also a full SJT mock, all right? So timed to the same timing, 110 minutes, 58 questions, like 110 minutes, 58 questions. Again, mixture, you'll do the section 1 questions and then you do the section 2 questions, just like the real exam, okay? So that's that. Now, in terms of the Crammer course, these are, some of the things that we've had feedback that, it's really helped people do really well. We've had lots of people get direct offers, especially the Crammer course is for you if you're applying somewhere really competitive, like London, or you're applying for a really competitive specialty, like radiology, like ophthalmology, or you want to get a direct offer, like in psychiatry or in GP, where you can get direct offers, because that maximizes your chance of getting sort of your first choice, okay? I'll tell you a bit more detail about that right at the end, for those of you that stay on, but I just want to talk about common reasons for failing, how to avoid them, how to prepare effectively, and then I'll take questions. And what I might do is I might do the summary first, and then stay back and take questions. I'll stay back for a bit longer. So why do people fail? Probably the number one reason is not allowing enough time. I think what a lot of people do is, they haven't even heard of the exam until after they've submitted the exam, the application, and then they get an email to book the SRA. And that's the first some doctors have heard of it. And because they haven't perhaps done some of the research and aren't prepared. So I'm really glad that you guys are thinking ahead and have come to this free webinar today. So at least you all know about the exam, okay? And one of the things that happens is people that try to cram it in like 2 or 3 weeks is that, if you're working and then you've got on calls, you're just not going to have time. Like, for example, even just to go through all 2,000 questions and mocks on our website and read the explanations there without then also reading textbook, just to do it will take at least 100 hours. We've timed it, okay? You can't do it in less than that if you're actually reading the explanations properly, all right? That's to go through it once. And some doctors, they'll use more than one question bank, and some will also then be doing some reading. And so, just think in a couple of weeks, that's really going to be difficult if you're working, you've got on calls, you've got family, you're tired. That's why we have some doctors, they start a year in advance and they just slowly a little bit around family responsibilities, other things. A lot of people will do 6 months or 4 months. Certainly if you haven't started, you really need to start now, because you've got less than 2 months if you sit it at the beginning. If you sit it at the end on the 11th, you've got just over 2 months. That is a realistic minimum if you want to do well. And it's not a pass-fail. The better you score, the greater your chance of getting your first choice job. And then underestimating the exam. Some people just turn up. I know of people that failed 3-4 times, and it's taken them several years to get in, because again, they just thought, oh, you know what, it's going to be straightforward. It's a challenging exam, not because individual questions are hard for the clinical, but because of the breadth. And for the SJT, a lot of doctors, especially if you don't have a lot of NHS or UK experience and aren't familiar, like those that did UK Foundation, you will have done Foundation SJT, and there's some similarities. But otherwise, it's a new type of question. It takes some getting used to, okay? Another problem, a lot of doctors focus just on one paper. So they do brilliantly in clinical, but do awfully in the SJT, and overall they do poorly. And then they don't get a good score. And finally, poor exam techniques. So these are the common reasons to fail. So how are you going to avoid them? How to prepare so you get band 4s? You want to do as much active learning as possible, okay? So, doing questions, making your own notes if you're doing some reading rather than just doing reading, okay? Make sure you cover the whole curriculum. You can do that by going through all the questions and then reading around things that you get wrong. If you get it right, just read the explanations we've got. We've deliberately made them concise enough that you can cover a lot of ground in a short amount of time. Make sure for the SJT that you've got a good understanding of not just reading the ethical guidance, but how to apply it in practical scenarios. Practice realistic questions. Many people have said ours are the closest to the real exam in terms of level, style, length, but also the screen layout. Work on exam technique. You can do that from doing the questions and at the course, and then do timed mocks. So we've got full-time mocks, 3 full-time mocks for the clinical, a full-time mock for the SJT, and then find a study partner or group. And then we've just launched today. We've had a GP training support group for many years, okay? Nearly 17,000 doctors in there. I know a lot of you are already members. It's the most active group for GP training. But we just launched today because a lot of people asked, they're looking for people to study with for the SRA support group, okay? I will send you the link to it in the post-course reading, okay? So join that. I post revision topics regularly. I will be posting questions every few days, and then I might post some video questions and explanations and rapid reviews as we get closer to the exam, okay? So I'll post a link to that in a minute. And in terms of practice questions, so many people have said that they found ours the closest, but in terms of the Crammer, I just want to share some feedback with you that we've helped lots of people, particularly for both people, but a lot of people said particularly for the SJT, that course really helps them understand how to approach SJT, because they spent 4.5 hours on that. So here's someone, they found that it was particularly helpful in demystifying the SJT, helped them get a direct pathway. This is last year, round 1, okay? They've got direct offer to their first choice in GP. Here's someone for radiology. Again, they used the bundle, the course and the online revision. They felt it made a major difference. They got their first choice radiology program, and they feel that they definitely wouldn't have got it if it wasn't for the course. The rapid reviews that we send, the encouraging motivation, so on, but particularly the course they found really valuable. And they're now actually in their 2nd year of training, okay, because this was last year, okay, or about to go in. Here's someone that got a direct offer for psychiatry, managed to get into the top 10%. You only need to about the top 20% for psychiatry to get direct offer, but they're in the top. They got a brilliant score, but again, they found it really helpful, the question bank and the course, okay, the Crammer course. And then for ophthalmology, again, they took the course. This is someone that had come to our SJT when they were a student. They found that so helpful. They came back to us for the SRA, but they got not just ophthalmology, which is competitive. They got their top preference job in London, and it's an international graduate, okay? In the days where international graduate, it was really, really difficult. Remember now, everyone's on an even level playing field just based on your score. So look, if you're a specialty that's competitive, or you want a competitive area like London, or you want direct offer for like GP or psych, the course and the online questions together are the complete bundle. So we offer a discount as a result. So the bundle gives you the Crammer course, You can pick any day, or the recorded version, or the live stream, plus the access to the 2,000 questions and the mocks for 4 months. So that's 250 instead of 319 anyway, because 4 months access is normally £89. But if you use the code SRA15 before Tuesday 11 a.m., you actually save over £100 in total, because you'll save another 15% off this already discounted price, okay? And so that, I showed you where that is on our website. Just find the SRA section, or that's the link, emedica.co.uk/SRA, okay? So just to recap the offer, then I'll do the summary, and then I'll take questions. Use the code SRA15. It will expire on Tuesday at 11 a.m., not a minute later, okay? You can use that same code to get a 15% discount on our SRA online for any length of time. Okay, so our SRA online, you've got the details there. You just click subscribe. When you click subscribe, you can pick any length that you want. So, 1 month, 2 months, 3 months, 4 months, 6 months. It goes all the way up to 12 months. You can pick whichever you want, okay? Put that code in and it will give you 15% discount. Or on the course, so the course, remember, you go to our main website, and then it's right here, Specialty Training, Recruitment Crammer, okay? Again, if you were to click book now, put the date that you want, and then enter that code, you'll get a 15% discount. Or on the case cards. The case card's actually on pre-order at the moment. Anyone that orders by tomorrow, it's already discounted. It's £20. Normally it's £26.99. The price will go back up to the normal price tomorrow, because we've sold out. They were so popular. So we're having a new batch printed. Okay, so watch out for that. Right. Time for questions. Apologies, I've run a few minutes over going through the practice questions. I think the clinical questions took a bit longer. So what I'm going to do, if it's okay, is I'm going to do the summary in case anybody's planning to leave now, and then I'll stay back and answer questions, if that's okay. All right. So I will send you links to all the things we've talked about, and some other useful resources by the end of the day tomorrow. I will also send you a recording of this, if the recording is able to be processed, by tomorrow evening, so that you can watch back any bits that you missed, or if you want to go over it, okay? And then I hope to see a lot of you either at one of the courses, or you might use our online, or if you want advice, if you're applying for GP training, we have courses for every step of, we have our Getting Into GP Training course that covers all the steps. That's running this Saturday. We have our Stage 3 course, specifically for the selection center. For psychiatry, we also have a course that's going to be launching in January, covering the interview, both the portfolio station and the communication and clinical station for the psych interview, okay? So let me do my summary. For anyone else, whether you come or not, I hope you found today helpful. Let me do the summary and I'll let you get away. So remember, it's a two-part assessment. Both papers are important because they both contribute to your total ranking. Now remember, whether you get shortlisted may be impacted in some specialties. And also, in all specialties, your total rank will be impacted by the SRA in different proportions depending on which specialty. It's not a pass-fail exam. It's a competitively ranked system. So every mark matters, okay? And remember, the scores carry over and get added to your interview score to make your total rank. So what to do between now and the exam? Focus your revision in a way that you can do both papers well. Try to practice under time conditions and do the full mocks. That will help you develop exam technique, okay? Now, finally, I want to leave you with this from Lao Tzu. The journey of 1,000 miles begins with a single step. And a lot of people, when they're applying for specialty training, it can seem like there's so many things. You've got to submit the application. That's really long, isn't it, on Oriel? You've got to prepare for both papers, and there's a huge curriculum for the clinical. There's so much ethical guidance to go through in the SJT. And then, you've got then to prepare for the next stage. If you think about all of that, it can be a bit overwhelming. So instead, just focus on one step at a time. And that first step is the hardest bit. And you've already taken that step by joining this today. You've got a clear idea about this exam. You know what to expect. You know how to prepare. You know the common mistakes that lead to failure, so you can avoid them. So all you need to do now is you just need to take one step at a time, okay? You've not already started revising, start revising. Each day, do something, okay? Take one step further, okay? One step further up here, eventually you climb the mountain, okay? Just each day do a little bit, even if it's just a few questions, one set of questions, reading one piece of ethical guidance, something like that. And then if you can, come to the Crammer course, you really consolidate your technique, cover a lot of high yield topics in one day. These are things you could read yourself, but it will take you weeks to cover how much we've condensed down into one day, okay? And then keep pushing, keep going, prepare, and you will succeed, okay? If you do the work, you're a talented doctor, you've got this far in your career. I guarantee you that if you put the effort in, you have the right technique and the right preparation, prepare, and you will succeed, okay? And I'd love to get an email from all of you come the results, just to let you know I got my first choice job in my first choice area, in my first choice specialty, okay? So those of you leaving now, thank you very much for joining me. I hope it's been helpful. You know, all the best.